We are live.
So, good evening, everyone, and I would like to welcome everyone, the audience who's here, as well as all the speakers and the panelists to this webinar, which is on ocular infections decoded. And this webinar is the initiative of the AIOSSC Scientific Committee, and it is supported by Lupin. So I would request Dr. Pranita Sai, who's working as assistant professor at RP Center, AIIMS, New Delhi, to give her opening talk on infectious conjunctivitis. We would be covering the entire gamut of infections, right from conjunctiva to retina. And over to you, Pranita.
Thank you so much, ma'am, and thank you for the opportunity for allowing me to present. I'll be talking about infective conjunctivitis. So conjunctivitis is one of the most common conditions that we keep seeing in our OPDs, especially in our emergencies, where patients come on with sudden redness in the eyes. And pink eye, as layman people commonly refer to it as, is the inflammation of the bulbar and palpebral conjunctiva. The etiology, as we all know, can be either infective or inflammatory, and today we'll be covering about the infective causes of acute conjunctivitis, of which viral conjunctivitis is the most common etiology. Viral conjunctivitis can be seen in all age groups. We see it in neonates, infants, adults, old age, and however, young adults are more commonly predisposed to this infection. And often these infections occur as outbreaks. Recently, in the past last 2 years back, we saw an outbreak of viral conjunctivitis in India as well. And similar outbreaks have been reported from various other parts of the world. So it is common to see these infections occurring in clusters. The etiology for viral conjunctivitis includes adenovirus, herpes simplex, enterovirus, varicella zoster. However, adenovirus is the most common etiology that we encounter in our setup. And during the pandemic, we also saw a lot of COVID-19 associated conjunctivitis. Adenovirus can cause two types of conjunctivitis. It can be either epidemic keratoconjunctivitis or pharyngoconjunctival fever, where in addition to conjunctivitis, fever, pharyngitis, and lymphadenopathy is also seen. And enterovirus is typically known to cause acute hemorrhagic conjunctivitis that is caused by picornavirus and Coxsackie. Now, the pathogenesis consists of two phases. One is the incubation period, which extends from 4 to 24 days. So it has a short incubation period. And however, the infectious phase lasts for 10 to 14 days. It is important to understand that although the symptoms last for 7 to 10 days, the virus shedding in patients almost lasts for 2 weeks. Hence, proper hand hygiene and isolation that we explain to our patients, the duration should be properly explained to them so that cluster infections or outbreaks do not occur. And we all know that it is highly contagious in nature. So even if one eye gets infected, one eye is infected, the other eye often gets infected. And once you see a child or anybody coming to your OPD, in the next OPD, you will have family members of that patient also coming in, because it tends to spread very fast. So it spreads by shaking of hand, coming in contact with fomites, contact surfaces like the doorknobs, and touching of the eye, contact with the contaminated secretions, and spreading it to others. And it can also spread via the respiratory droplets.
मैंने लिंक नहीं शेयर किया, मैंने सिर्फ लिंक शेयर किया। आगे किसको गया मेरे को?
So the clinical features, often the infection is unilateral to begin with, but second eye infection is often seen in almost 70% of the cases. And the symptoms with which patients present includes redness, watering, foreign body sensation, lid swelling, and sensitivity to light. Pain is not very common in conjunctivitis to see with. If you're seeing a patient with pain, then alternate diagnosis should be there in mind, or a complication of conjunctivitis is likely that you will see. So the most common thing that you see in these patients include diffuse conjunctival congestion. As you can see here, there is a diffuse congestion, unlike uveitis or other condition where you will see only a circumciliary congestion. If you invert the lid, follicles is something that you will see in these eyes. And subconjunctival petechial hemorrhages, which is typical for adenovirus, can also be seen. Conjunctival chemosis. Discharge predominantly is watery and is what differentiates the viral conjunctivitis from bacterial. The discharge in viral is going to be predominantly watery, while in bacterial, you see purulent discharge. And lid edema, you can see this was a child of ROP who was screened, and following ROP screening developed bilateral viral conjunctivitis, and a lot of lid edema can be seen here. So the diagnosis of viral conjunctivitis is predominantly based on the clinical finding. Viral PCR, cell culture, direct immunofluorescence, and rapid antigen detection have all been reported, but predominantly it is based for research or scientific study-related purposes. In the OPD, the diagnosis predominantly is based on our clinical findings. So any patient of acute conjunctivitis that comes with, congestion, follicle and petechial hemorrhages, what do you need to explain? You first and foremost is to explain hand hygiene and the importance of explaining isolation, and not to share, bed sheets, towels, pillows. And for symptomatic relief, what you can tell them is cold compresses with ice pack, lubricants, and sometimes topical NSAIDs can also be given. We'll talk about topical povidone iodine role in viral conjunctivitis in subsequent slides. What is important to remember here is that there is no role of giving antibiotics to these patients. Only if the patient is coming with a pseudomembrane that you have peeled, that obviously requires a peeling, that you add a prophylactic antibiotic can be added, and a low potency steroids can be added in these patients. Also, if the patient has pneumolar keratitis involving the visual axis, that is when you will require steroids in the management of viral conjunctivitis. Per se, we usually do not start steroids in these patients. This was a flyer that was circulated by AIOSSC during the outbreak of conjunctivitis that we had in 2023, wherein the basic protocol of hand hygiene and how to avoid and spread of the conjunctivitis was being circulated for common people. And this can be used in our OPDs to increase awareness among our patients. Now, the complications that we see in viral conjunctivitis include pseudomembranes and pneumolar keratitis. These are the two most common complications that you need to watch out for. Pseudomembranes can be seen in severe conjunctivitis. It is just a fibrin and exudate deposit, which needs to be peeled and removed. If you don't do that and allow it to stay there for a longer time, it can result in conjunctival scarring and some blepharon formation in rare situations. Pneumolar keratitis, as you can see in the figure here, which is more commonly seen in adenoviral conjunctivitis, appears as a grayish-white lesion with fuzzy borders and is located subepithelial. As you can see here in the AIOSSC with the red arrows, the location of these lesions are subepithelial, and the patients usually present with glare, halos, and diminution of vision at second to third week of onset. So it is again important to explain to our patients that they need to be on a close follow-up, and just the resolution of redness and symptom is not enough. Second to third week is when they may develop these pneumolar keratitis, and if it is involving the visual axis, steroid therapy may be needed for these patients. It is again important to differentiate the two different patterns of pneumolar keratitis. While adenoviral cases you can see small lesions which are uniform in size. In herpetic keratoconjunctivitis, the lesions are coarse, large, and variable sized. And for herpetic keratoconjunctivitis, you may need to add on antiviral therapy along with the steroid drops that you give. So this we have already discussed, and often these patients do see recurrences in such a situation. Topical immunomodulator can be given for a prolonged duration to reduce the risk of recurrences, which these patients are often prone to. And they have a self-resolving course. So only if these lesions are involving the visual axis or affecting the visual acuity, that warrants treatment with low potency topical steroids. Now, there are a few controversies related to viral conjunctivitis, and we'll take on these topics: the role of steroids, role of povidone iodine drops, immunomodulators, and topical antivirals. So role of topical steroids is always controversial. While it reduces ocular inflammation and symptom relief, and it improves the patient comfort very dramatically, but it also prolongs the viral shedding and is known to increase the risk of transmission. So there are some systemic reviews, articles, and meta-analysis that have looked into the role of topical steroids, and they say that if you prescribe it in cases of acute epidemic keratoconjunctivitis, when compared to just lubricants, the risk of developing subepithelial infiltrate is less with steroids. However, in patients with chronic epidemic keratoconjunctivitis, when steroids were compared to immunomodulators, there was no difference in the elimination of subepithelial infiltrate or in the risk of recurrences. So in acute epidemic keratoconjunctivitis, this meta-analysis do suggest that steroid reduces the risk of subepithelial infiltrate, but risk-benefit ratio needs to be looked into, and they have to be prescribed cautiously. Looking at the role of povidone iodine. So povidone iodine releases molecular iodine, which has virucidal activity and reduces transmission, and it can be used as a single-time irrigation agent in the OPD, or can be prescribed as topical drops. And we have a lot of topical drops that are already commercially available for prescription. So a lot of RCTs have also compared artificial tears with povidone iodine, and it says that the symptom resolution in patients with povidone iodine group is faster when compared to simple prescription of artificial tears. Now, there has also been this Cochrane review article, which has looked at various aspects of management of epidemic keratoconjunctivitis, and important questions have been addressed. So they have compared basically artificial tears with various interventions for symptom resolution, and they suggest that even a simple povidone iodine with or without steroids causes faster resolution of symptoms compared to artificial tears. Although the level of evidence is not very high, but they show a benefit with the prescription of povidone iodine. And for subepithelial infiltrate development at day 21, they compared steroids with lubricants. So they suggested the results of the study again was in favor of steroid prescription compared to controls for the development of SEIs or subepithelial infiltrate. Now, comparing any treatment that include povidone iodine with or without steroids versus artificial tear, even simple povidone iodine also reduce the risk of some epithelial infiltrate development compared to just prescription of lubricants. Moving on to the role of topical immunomodulators. So topical immunomodulators compared to steroids, there was variable response. Some say there is no major difference between the two, and one study shows a favorable response for tacrolimus. So one of the areas which has not been explored much or is of limited use is the role of topical antiviral. Only limited 2 studies have assessed the role of ganciclovir and trifluridine in cases of viral conjunctivitis. While one study gives a favorable result, the other one does not show any beneficial results. So the role of topical antiviral is controversial. So that is about viral conjunctivitis. So I'll just show you one case. This was a case of viral conjunctivitis that was being treated elsewhere with topical steroids, came to us. Non-resolution of symptoms at 10 days of symptoms. Onset that he came to me. So you see there are white necrotic patches that are seen here. And on a simple fluorescent staining, you see there are a lot of conjunctival ulcers. And on rose Bengal stain, you can see fine dendrites evolving at the limbus. So that is an adverse effect of prescription of topical steroids when you're prescribing it in cases of viral conjunctivitis, especially herpetic viral conjunctivitis, of which we can never be sure of when you treat these patients, because HSV PCR or viral markers are not something we routinely get for our patients. Hence, steroid prescription should be very cautious because we can have viral involvement of the cornea. And with a simple eye ointment acyclovir, by 48 hours, there was complete resolution of these ulcers. And by day 7, he had almost complete resolution of the redness. We also reported this case in BMJ. Now, moving on to the next part, which is bacterial conjunctivitis, although it is not very common nowadays, but still it constitutes almost 20 to 25% of the conjunctivitis cases seen worldwide. Staph, strep, Haemophilus, and Moraxilla are some of the common pathogens that are implicated in the bacterial conjunctivitis. And the course of disease usually lasts 7 to 10 days. In contrast to viral conjunctivitis, you see a lot of matting of the eyelashes and purulent discharge. You can see this purulent yellowish discharge and matting of the lashes, stickiness of the lid, and congestion. Another subset is a hyperacute bacterial conjunctivitis, which is seen by Neisseria gonorrhoeae, and you see copious purulent discharge in this case. So when you are treating this patient, it is important to send a conjunctival swab for microbiology. Whenever you see a purulent discharge, send a smear for gram staining and a culture sensitivity of the corn swab, so that you can have a microbiology report with you and start topical antibiotics. So this is a systematic review done for conjunctivitis, which shows that the various drugs that give a level A of evidence for management of bacterial conjunctivitis. This includes tobramycin among the aminoglycoside group. For the fluoroquinolone, we see moxifloxacin, ofloxacin, and becifloxacin to have a level A evidence for management of bacterial conjunctivitis. And even combination drop, polymyxin B and trimethoprim, has a level A evidence for management of bacterial conjunctivitis. Hyperacute bacterial conjunctivitis needs to be managed differently. You need to give systemic antibiotic, ceftriaxone, single dose, intramuscular, along with the topical antibiotic. And 7 days of therapy with topical antibiotic is usually good enough to manage these cases. So topical antibiotics for 1 week, a broad spectrum antibiotic, and a good hand hygiene is something which is required for the management of bacterial conjunctivitis. And topical steroid is an absolute contraindication when you're managing bacterial conjunctivitis. So like you see pseudomembranes in cases of viral conjunctivitis, this was a case who presented with such severe membranes that it was mimicking almost a sloughing corneal ulcer. And a corn swab was sent, and this was positive for Streptococcus pyogenes. And within 48 hours of starting antibiotic therapy, you can see these membranes organized, and we could see the clear cornea behind, and then the membrane was peeled, and the conjunctivitis resolved to simple fluoroquinolone therapy with gatifloxacin. Last but not the least, microsporidial keratoconjunctivitis is also something not very commonly seen. But in all cases of conjunctivitis, examine your cornea as well, because these lesions are so subtle that they can be missed if you are not looking at the corneas very carefully. So these are basically microsporidia as a parasite and is an infection usually transmitted by waterborne infections. They are usually unilateral but can become bilateral, especially in immunocompromised patients. And what you see here are punctate white, gray, raised, stuck-on lesions on the epithelium, which often take up stain with the fluorescein. And minimal discharge or watery discharge is what you see. Sometimes it can be associated with endophthalmitis, and you can see AC reaction in KPs as well. A simple scraping and stain with gram stain and KOH will give you a good picture. However, the diagnosis is predominantly based on clinical examination. And management includes with fluoroquinolone therapy itself. Sometimes, rarely, you can have a stromal microsporidial keratitis wherein the overlying epithelium is intact and you see stromal infiltrates in these patients. Management is with fluoroquinolone therapies, mostly suffices in majority of the cases. Sometimes oral albendazole can be given, and topical antifungal in the form of voriconazole is also being used by few. And steroids and immunomodulator can be used to reduce the inflammation after 48 to 72 hours of treatment initiation. So this was a microsporidial epithelial keratitis, which was treated just with simple Vigamox 1 hourly, and it responded well to treatment. And every conjunctivitis that you see is not always infective. Sometimes you can have a patient coming like this, a lot of discharge, but if you closely examine the other parts of the body, you can see this patient had oral ulcers, skin lesions on the fingers, and this was a case of Behçet syndrome presenting as acute conjunctivitis. So to conclude, conjunctivitis can have variable causes. A careful clinical examination mostly is sufficient to diagnose these cases, and most of them have a self-limiting course. Viral steroids have to be used cautiously. Bacterial responds well to antibiotics, and systemic assessment should also be done in cases where the diagnosis is not getting explained by the simple eye findings. With that, I will conclude. If there are any questions, I'll be happy to take.
Thank you, Pranita. I think that was a very exhaustive and comprehensive overview of conjunctivitis, which you covered, and so apt in this season when, conjunctivitis has suddenly increased. Anybody would want to, Ellen, would you want to comment on it or ask?
So it was very well covered, ma'am, particularly the aspect. There are a lot of general practitioners as well as a few ophthalmologists writing steroids on first contact with conjunctivitis, viral conjunctivitis. So it was very well covered when they have to use the steroid and what is the right treatment for viral conjunctivitis. She had covered it very well. lubricants plus povidone iodine or a mild antibiotic. And when to really use the steroid, she had given a very good.
Madhu, what about povidone iodine? What do you think of povidone iodine, which is the new weapon which has come for, getting combating the nummular opacities, and especially in adenoviral keratoconjunctivitis?
Povidone iodine, my experience has been very limited, ma'am. But mostly nummular keratitis, we manage with cyclosporin and tacrolimus ointment. We need not use steroids also. But as you have told, this new evidence we have to see. The only thing is how patients will be tolerating the stinginess of povidone iodine in these cases, and how practical would it be to do it.
But adding, I just wanted to add this, adding povidone iodine, diluted povidone iodine, I don't use the 5%, I further dilute it with artificial tears. Reduces the chances of getting nummular keratitis. In the same family, if we compare. I not did a study, but definitely that is my opinion.
Yes, sir. Yes, sir.
Praful?
Thank you, Pranita, for a comprehensive talk. As the point of discussion was steroid. So, what is your recommendation for a general practitioner dealing with a case of conjunctivitis to start steroid? Which are the cases where the steroid should be started? Which are the cases where steroid should not be started at all?
So for viral conjunctivitis, steroids are only to be started if you're seeing pseudomembranes and severe chemosis. These are the cases only where topical steroids should be given. And if in the sequelae phase or in the second, third week, nummular keratitis involving the visual axis that is compromising the vision is when a short course of topical steroids can be given.
Any specific indication for hemorrhagic conjunctivitis?
Severe chemosis, severe lid edema, to which the patient is having excessive symptoms. That also I would be very cautious in prescribing them.
So just to summarize, if a patient is having, as she said, pseudomembranes or membranous conjunctivitis, severe lid edema, all this thing, or if you are suspecting hemorrhagic conjunctivitis, then I think these are the three indication, or even hemorrhagic conjunctivitis caused by picornavirus. So these are the indication where you can start steroid, and rest of the cases I think one should avoid. And you showed one picture of that pseudomembrane. So what is the ideal treatment when the patient presents with membranous conjunctivitis? How to deal such cases for a practitioner, general practitioner?
I think Pranita's connection, there is a problem because
I think, okay.
Yeah.
screen is frozen.
So I'll share the details about that case. Actually, that case was referred to me as a case of corneal melting, the photo that she said. And I couldn't open the eye. So I said, okay, we'll do EUA. So we took the kid to the examination under anesthesia part, but the anesthesia refused. Then I said, okay, we'll forcibly open and see what is there inside. And when you open the eyelid, it was just a membrane. So membrane conjunctivitis can be confused with corneal stromal thinning and keratitis. That is a very important part that practitioners should remember at least. And at the point of discussion, ma'am, that you started about povidone iodine. So if Pranita is online, is there any update? Because, there was a trial going on about povidone iodine plus dexamethasone combination in adenoviral conjunctivitis. It was a multi-centric trial. If Pranita is online, then she can...
Yes.
She's
Just
online.
connected.
Come back to answer the question. Saved us the
Question.
agony.
I just got logged out. Yes, sir. What was the question? You got mute.
The
muted.
trial,
Now you have muted yourself, Praful.
Yes.
Pranita, any update on the dexa plus povidone iodine combination drug? That was a multi-centric trial. I think it's going on since the last 8 years.
Yes, sir. So I
Yes.
think I showed in my slides. There are 2-3 studies. I'm not sure which one are you talking about, but in this meta-analysis study, they compared povidone iodine plus steroids versus lubricants for looking at development of subepithelial infiltrates at day 21. So they saw that there was a benefit of povidone iodine with steroids versus lubricants for reduced risk of development of subepithelial infiltrate. However, there's another study which compared only povidone iodine with lubricants, and they saw less risk of subepithelial infiltrate for development at day 21.
Very true. So this is what is important. The drug that is under trial is a combination of povidone iodine and dexamethasone. And the strength, as Ilan sir was telling, its strength is hardly 0.5%, not 5%, it's 0.5%. Even the other drug is 0.25. So they are trying that combination, that is with dexamethasone. So that is showing promising response because iodine takes care of the your microorganism part and steroid takes care of the nullar infiltration. However, I think that is still not there in the market. Once it comes, then it will be a good addition to our
Yeah.
armamentarium for dealing such cases. Any last question, if I'm not taking too much time? You showed one patient of pediatric conjunctivitis. Any specific
Yes.
guideline for the practitioner when you're dealing with the pediatric conjunctivitis versus vis-a-vis your adult conjunctivitis? How the approach differs?
So, sir, that was a case of post-ROP screening. The child was 6 weeks. I tried to look into literature if there is any specific guideline for it, but I could not find that. But what we routinely do is at least we send a conjunctival swab for culture, even if we are suspecting viral, but to be more, certain, I do send a conjunctival swab for culture and start these patients on antibiotic. While it is not recommended in viral conjunctivitis, but the pediatric eyes are already compromised. So avoiding the risk of any infection, antibiotics is also something that I do prescribe in pediatric cases. Any difference of opinion, ma'am will be a better person to answer.
No, I think you've answered well. Pranita answered like a JR in front of Professor Praful Marana, who's firing. But I think these are the points which need to be clarified. What would you do for pediatric keratitis, whether you would give povidone iodine or not? And I think I agree with you completely. Whenever you have a pediatric microbial keratitis, you would send a swab and you would definitely start antibiotics and sometimes stronger antibiotics.
Single time installation of povidone iodine in the OPD is also something I do for these kids.
Praful, any difference before we move to the next talk?
So the standard dictum that one should remember is when you're dealing with an adult conjunctivitis, most likely it's a viral conjunctivitis. But when you're dealing with a pediatric conjunctivitis, most likely it's a bacterial conjunctivitis. So adult conjunctivitis for 48 hours, you can skip antibiotic. A lot of physicians, they avoid giving antibiotic for initial 48 hours. If there is worsening, then you can add subsequently. But for pediatric conjunctivitis, you have to start an antibiotic. So that is the catch. When you're dealing with pediatric conjunctivitis, antibiotics are the first line treatment.
So do you give single antibiotic or double antibiotic?
Do you give?
Do you give single antibiotic or double?
No. The most common organism is Streptococcus only. Streptococcus pneumoniae is supposed to be the most common organism. So usually any antibiotic that covers Streptococcus, that is good enough.
Prafula, I had a question, so quick one.
Yes.
One
Dr.
is
Piyush.
just to reconfirm that you said that it is 0.5% of povidone iodine.
0.6.
0.6%.
0.6 with Dexa.
Okay. No, and
Dexa, I think
what you use
1%.
only povidone iodine is not in the protocol.
As per the literature, only povidone iodine, the results are mixed. But I think in 2023, there was a publication by Propose et al. Or Pipos et al. I'm forgetting the name, sorry. So they have analyzed this 0.6% povidone iodine with dexamethasone, and they found that the viral clearance is almost 31% better compared to the standard treatment. So it was statistically significant. So they have some good results. But I don't know how far the marketing study, I think it's a phase 2 trial. So they will be doing phase 3 trial and then probably it will come into the market.
And when do you recommend this being started? Like Pranita said, when there is pneumococcal keratitis, or do you have any other reasons why you would want to start it?
So that's a huge debate, I think. But Dr. Namta can also join in. So there are different approaches, So one approach is if you are starting steroid, then don't taper it off soon. Because if it's a severe conjunctivitis, hemorrhagic conjunctivitis, and severe chemosis, all these things are there. If you have started steroid, then taper it over a period of 3 to 6 months. Maybe you can combine cyclosporin to that. If you haven't started steroid and you see infiltrate which are not central, or confluent, it's better not to start steroid at all, because the studies have clearly said if you start steroid late in nummular infiltrate, unnecessarily you are going to prolong the viral shedding. So I think if you're starting steroid early, it's fine, then continue it for a long time. If you haven't started, infiltrate have appeared and not affecting the visual acuity, it's better to avoid steroid in such cases.
Yeah, but having said this, I think one more important thing is that you can't afford those nummular opacities to scar in the center, because then the patient is going to lose the best corrected visual acuity. So judicious approach has to be taken about starting steroids and with cyclosporin, so that when you taper them off, the cyclosporin takes over. Okay, Praful, can I share my presentations?
Yes, ma'am. So next, I would like to invite Professor Namita Sharma, ma'am, for her lecture on a new drug. And you all know, ma'am, she needs no introduction, but I will introduce her. She has written a cornea ulcer book. And I think everyone of us has gone through that book. And she has done extensive work in infections in cornea. And other than the political affiliation, she has done a lot of research. She has 600 plus publications. So I think she's the right person to discuss a new molecule, new combination for
So
keratitis or infections in ocular
thank you so
surface.
much, Praful and Pranita. Two of my students are here, and Ellen. But Ellen is now a senior most student here.
No, always a student.
So thank you so much. And I would be talking to you about next generation moxifloxacin with retention enhancing delivery system. So we look at various infections. I think antibiotics is something which is required for all of them, whether it is conjunctivitis, keratitis, endophthalmitis, even STI, blepharitis, uveitis, cellulitis, or dacryocystitis. And bacterial infections of the eye, again, looking at the pathogens, bacteria are the major contributor of ocular infections. If you look at worldwide, they contribute to 32 to 74% of the eye infections globally. And any layer or any part of the eye may be afflicted with the infection. As far as the bacterial conjunctivitis is concerned, I think Pranita has covered it wonderfully, and about 6 million people are affected annually in US by bacterial conjunctivitis, which is the second commonest cause of conjunctivitis after viral. It is highly contagious, and of course, the organisms as well as the therapy have already been enumerated. Apart from this, you do have infectious keratitis, and bacterial infection is again the most common form of infectious keratitis, and Dr. Madhu Daraju is going to talk to us about it. And then you have post-operative endophthalmitis, which is, I think, the most devastating infection which can occur in the eye, and more so if you have cluster endophthalmitis, they even force temporary shutdown of the operation theater. So the causative organisms of post-op endophthalmitis, 70% are gram-positive coagulase negative cocci, 10% are Staph aureus, followed by Streptococcus, Enterococcus, other gram-positive species, and then we have gram-negative bacteria as well, which causes infections, which are shown here. And fourth-generation fluoroquinolones are the most commonly used topical antibiotics. Again, this is a list of organisms which are infecting, which do involve the eye in infection. Now, this is a very nice paper on bacterial profile of ocular infections, a systematic review, which again said, having looked at all the publications, that gram-positive bacteria are the major contributors of bacterial ocular infections, and there are various bacterial isolates which may be responsible for the same. Now, this is the common bacterial isolates in various ocular infections. And again, you can see that the species that we were talking about is the commonest across all over the world, even if you take location-wise. And the same holds true for keratitis as well. And these are infections other than keratitis. Again, if we look at the various organisms, the organisms continue to be the same, the gram-positive bacteria as well as the gram-negative bacilli. Now, we have gone through the various generations of fluoroquinolones, and currently we are all on fourth generation fluoroquinolones, such as gatrofloxacin and moxifloxacin, which are most widely used mainly because of increased antibacterial spectrum. And the fourth generation fluoroquinolone does have excellent penetration with good PK/PD profile. superior solubility, excellent bioavailability, significant for surgical prophylaxis, reduced potential for development of antibiotic resistance, and enhanced activity against the isolates resistant to second and third generation fluoroquinolones. And of course, they are quite comfortable because of the pH that they have. Now, we prefer moxifloxacin to other antibiotics in all the surgeries because they are preservative-free, which our option is available. They have increased penetration into the ocular tissues and fluids, broad spectrum of activity with greater potency and high rate of clinical success. Now, the moxifloxacin, which is from our sponsors, that is the Lupin, is different from the conventional moxifloxacin. If we look at the pharmacological concentrations, it is probably similar. But if we look at the other ingredients like xanthan gum, the triloxapol, USP, boric acid, sorbitol, sodium chloride, sodium hydroxide, or hydrochloric acid for pH adjustment, these are the things which are different from the conventional moxifloxacin. And this moxifloxacin comes in twice daily dose, which is again, the patients are compliant. And the xanthan gum has retention enhancing delivery system to prolong the retention on the ocular surface. So as a result of which, there's reduced dosing frequency as compared to conventional moxifloxacin, and there is better patient convenience as well as compliance. Now, if we compare again the conventional moxiflox with the moxiflox, which comes with the xanthan or MXG as we call it, this is twice a day dosage, whereas the conventional moxiflox, it comes as TDS dose or as QID doses. In children, we talked a lot about the pediatric keratitis. In children, more than 4 months also, you can give this formulation, whereas the conventional moxiflox is approved for more than 1 year. It is tolerated well because the pH is equivalent to the natural tears, which is 7.4 as opposed to 6.8. The ocular tissue penetration is almost the double. The bioavailability is also almost the double, and it can act against 20 types of bacteria which cause infection as opposed to 13 bacteria in moxiflox. And there are various organisms in endophthalmitis also on which it can act. Now we look at the clinical evidence on next generation moxiflox with retention enhancing delivery system, that is with xanthan. This was a study which was done, a randomized double-masked parallel group clinical trial done in 6 US sites, comparing conventional moxifloxacin with a new 0.5% ophthalmic formulation with xanthan gum moxifloxacin. And 130 patients were scheduled for cataract surgery. They were randomized to receiving either of the moxifloxacin, that means Moxi, or MAF, which contains the xanthan gum formulation. The groups in terms of the age were well matched, and the conjunctival moxiflox concentration data was obtained from these 127 patients to look at the pharmacokinetics. The inclusion criteria was patients more than 18 years of age and any gender, and of course, all the exclusions which are there for moxifloxacin, like sensitivity to fluoroquinolone or to one of the vehicle, or use of other topical medications within 30 days, or evidence of any other significant disease, and women who are pregnant or were breastfeeding were excluded. Following the dosage, they were at 0.25, 0.513, or 5 hours post-dose, the 2 conjunctival samples were obtained, and concentrations of the moxifloxacin were determined, and they were validated, and again they were compared. So if we look at moxifloxacin and compare it with the newer molecule MAF, then one can see that the conjunctival concentrations are nearly doubled and more with MAF as compared to the conventional moxifloxacin. And if we look at the peak levels within 15 to 30 minutes, so the Tmax, then also it is much higher. And mean moxifloxacin conjunctival concentration levels at all points in times are in fact higher. And the Cmax in the conjunctival tissues is also higher. So there's a 337 to 730-fold greater Cmax value of MAF as compared to the conventional moxifloxacin, which is reported for Staph aureus, Strep pneumoniae, and Haemophilus influenza. And this is again to show the pharmacokinetic parameters for moxifloxacin after single dose of MOXIE or MAF, and to compare the various concentrations of both these formulations. Again, this also highlights the same. So it does ensure that you have a better ocular penetration and bioavailability as compared to conventional moxifloxacin. Now, we all know that fluoroquinolones do work in concentration-dependent manner, and so superior penetration, which is observed, could translate into greater eradication of the bacteria. Then an enhanced bactericidal effect of moxifloxacin while reducing the amount of the drug applied to the eye is by 30%. That means 2 drops versus 3 drops over 24 hours. And of course, there is reduction in frequency, which is twice a day, and this may be a challenge, especially in children who have problems commuting to school and may not have access to medications during the school hours. Now, this was another study which looked at microbiological efficacy of this formulation of moxifloxacin in bacterial conjunctivitis. And again, this looked at 1,180 patients. 1 drop was given twice a day for 3 days. And again, microbiological specimens were obtained on day 1, day 4, and they were processed using routine clinical microbiology tests. And the success rate for patients treated topically with MOXIE-AF BD for 3 days was 74% versus 56%. Again, as compared to vehicle, which was again statistically significant. And if we compare the rate of eradication of the 3 principal conjunctivitis pathogens, then again, it is much higher, close to from 86 to 98%, vis-a-vis 50 to 80% as compared to the conventional moxifloxacin. And again, this is at day 4, which again looks at the microbiological intent to treat population and modified per protocol population, where again the percentage who were successfully treated is much higher with MOXIE-AF as compared to vehicle. And even eradication rate by species at day 4 is much higher with MOXIE-AF as compared to vehicle. So the study concluded that xanthum gum-based 0.5% moxiflox formulation, MOXIE-AF, provides effective eradication of the 3 principal causative pathogens across all age groups, and especially when dosed twice daily for 3 days. Now, this is something which looked at the various coverage of the bacterial coverage, and 20 species vis-a-vis 13 species that I talked to you about when we compared it with a conventional moxifloxacin. Again, it is effective against gram-negative bacteria as well, which is causing post-op endophthalmitis, whether it is E. coli or it is Klebsiella species or Propionibacter acnes, Enterococcus faecalis or Staph mitis. Now, when we compare the age at which it can be given, I think this is the only fluoroquinolone which can be given in pediatric patients, which is 4 months and above, when we compare it with all the other fluoroquinolones, which have to be given in higher age. And again, discomfort is not there with this. Eyelid edema is also not there. Foreign body sensation, itching, conjunctival hyperemia is minimal, which is also reported with other fluoroquinolones, and transient burning is also not there if we compare it with other fluoroquinolones. That is to say that this possibly happens because of the pH, which is very much similar to the natural tears, which is 7.5. So like I said earlier, this is from the dossier that comes with it. It has moxifloxacin, which is of course patented, the way they make it, and other ingredients which I have already highlighted before. And the dose and the mechanism of action, as well as drug interactions, have been discussed. There are no major drug interactions which have been, which are there with moxifloxacin eye drops, and unlikely that it will interact with any other drugs. Then, of course, side effects, I think rarely these adverse effects have been reported, such as eye irritation, or only in about 1 to 2% of the patients, out of studies which have been done over 1,000 plus patients. Of course, this is the packaging information. It comes in a pack of 3 ml. Shelf life is 24 months. storage is at temperature below 25 degrees and you have to protect it from light. So all these have been highlighted, the advantages of the next generation moxifloxacin twice daily. And we've also used it with very good results. And thank you very much for your kind attention.
Thank you. Thank you so much, ma'am. Any comment from the panelists? Any experience of using this drop? Ilan sir, Prashant sir, Dr. Piyush?
No, I don't have any experience to using this drop, but 2 times dosage is very attractive considering that's what the patient asks.
Madhu sir?
Shall I go ahead?
Yes, sir.
Okay.
Achha, sir, what about your talk? Sir, I was asking about your any experience of using this new moxifloxacin.
Yeah. This drop I usually prefer in when I remove foreign bodies.
Okay.
When you remove a foreign body, you leave an epithelial defect, and there you want to have a prophylactic usage instead of your regular drop. I think xanthan gum here, it forms a film-like thing and it helps in epithelial healing. That is why, so my foreign bodies will always get this drop as a standard.
Basically, viscosity enhancer, I guess. Ma'am?
Exactly. Gel formation mein rehta hai na?
So tolerance is much better.
Better, far better, madam. Yes.
Patients are comfortable. So I
Yeah.
think we can move to the
I
next
think
one.
they were the first thing. After them, very nice. Yeah.
We can move to the next talk, Praful, I think.
Okay.
Praful, please introduce Dr. Madhu.
No.
Ma'am, I think, should I introduce her?
Yeah, please.
Yeah. So
Sorry, my
next
internet is not weak. Yes, Panita, please introduce it.
So our next talk is going to be on the practical of the microbial keratitis by Dr. Madhu Udaraju. Sir is currently working as a co-chair at the Vision Tree Super Speciality Eye Care Center. He has done his fellowship from Arvind Eye Hospital and is also trained for Boston keratoprosthesis from Harvard and has done his fellowships from SNEC Singapore for laser refractive surgeries and for limbal stem cell surgeries. He has been trained from Italy from the Unimore Hospital, and he has done over 2,000 transplants in a short period of 6 years. He has trained several fellows and published various articles in international journals and has also won several national and international awards. So we welcome you for your talk on management of microbial keratitis.
Thank you so much, Pranita, for that wonderful introduction. And I thank Namrata ma'am for allowing me to be part of this wonderful session, because microbial keratitis is that's something very close to my heart, being trained under MS sir. So, and I thank madam for giving me this opportunity once again. There are no financial disclosures. So the scope of this talk would be under the following headings. We'll briefly discuss causative organism, clinical diagnosis, how you differentiate based on the clinical features, role of microbiology, medical management, intrastromal injections, therapeutic grafts, and the take-home message. So if you see causative organisms that we commonly see, the majority would be either fungal or bacterial. Then we have uncommon organisms like acanthamoeba, nocardia, microsporidia, pythium. Sometimes it can be a combination becoming polymicrobial. Viral also can be a cause for keratitis. Because of the time given for this talk, I would exclude viral keratitis from this. And I thank Pranita for covering microsporidial part. It will save time in it. Yeah. So history and clinical science, if you see, the major differentiation between fungal and bacterial keratitis as described are, you can see a serrated margin and raised profile in case of a fungal keratitis, whereas in bacterial, it is defined and flat profile. And history also, usually you see trauma, and sometimes here it would be a contact lens wearer or something like that. So coming to fungal keratitis, it's the early stages where we usually try to get and confused and try to misdiagnose it. So if you see here, it has this early dendritic pattern. When you see this dendrite, it's actually a pseudodendrite. Okay, so early fungating, hyphating branches of this fungal keratitis are seen like this. So you should not confuse it to viral keratitis. So next, this is the classical picture that you don't usually miss. So here you have the typical feathery margins, satellite lesions, and sometimes you also have this typical plaque that is superficial. And then you have endoexudates that are more commonly associated with fusarium and aspergillus. Anterior stromal, usually it's fusarious. Next, fungal keratitis, as it advances, becomes like this total corneal abscess involving the limbus or going into a perforation. So fungal, the simplest diagnosis is KOH, and under the microscope, you can see this beautiful filaments, and KOH itself is 80% sensitive. Gram stain, again, you can do it. Next, if you can have a SDA or PDA, you can see the growth like a cottony fluffy growth. And this is how the fungal filaments will look in confocal microscopy. So if you see here, confocal microscopy has a role in deeper infections where you can't have this ulcer accessible to corneal scraping. So if you see here, the corneal slit is clear, but this particular infiltrate is extending from the cataract surgical wound into the AC. So here, if you see the depth of in vivo confocal microscopy, it is 834, and here you can easily make out this fungal filaments. Okay. So fungal keratitis, the modified TST protocol is what we follow according to Namrata ma'am. It has been very effective. So for filamentous fungi, we give 5% natamycin 1 hourly. Voriconazole, we add in cases of aspergillus or ulcers that are not healing to natamycin. And the most important thing is avoid monotherapy of voriconazole. If you see in MUD study, monotherapy of voriconazole alone will have higher perforation rate when compared to combination therapy. And for night cover, we usually give an itraconazole eye ointment. Symptomatic treatment, we give atropine analgesics, anti-glaucoma drugs, and sometimes we also add oral doxycycline, especially where you have corneal melting. This is for its anti-MMP activity. Therapeutic debridement is a must. As you do in every follow-up, you need to therapeutically clean the entire surface of the ulcer so that it reduces the fungal load and also increases the drug penetration. So in cases of limbal involvement and deep stromal ulcer, systemic ketoconazole is what you can do. For candida, you can try amphotericin B. Intrastromal voriconazole, I'll discuss in the next slides. Early TPK is what we do. Suppose we are doing you have diagnosed fungal keratitis, you have given all the treatment, you have tried intrastromal voriconazole, it doesn't respond in 3 weeks. That is when you go and do a therapeutic graft. Don't let it spread to the limbal involvement or don't let it spread too deep. Both these conditions will reduce the outcomes of a therapeutic graft. And cross-linking is definitely not recommended in these cases. And role of tacrolimus may be there, but we have seen only in cases of animal models. So why specific therapy for ulcers? Because most of you regular practitioners would be seeing this webinar. So why do you feel that empirical therapy is not as effective as a specific therapy? Two reasons. One is the drug compliance. The more number of drops you give, the compliance will try to come down. So the antifungal, instead of going 1 hourly, if you give a antibiotic along with it, the frequency may come down to 1.5 hours or 2 hours sometimes. So that is the reason drug compliance is number one. And one more important point is if you leave the commensal bacteria as it is without giving an antibiotic, they also act against the fungus. So these two conditions help the specific therapy more. That's the reason the ulcers that are treated by corneal people heal faster than a general practitioner. Next, coming to intrastromal injection, I'll just show you a video. So if you see, this is the graft host junction. So you can see the corneal abscess there. And I'm trying to drain that abscess. And here it is, you can see the turbid fluid coming out. It's very turbid. It can't be taken out from the needle. So what I'm trying to do is I will try to give 2 or 3 more. Just to liquefy that part and just remove the needle, and with tuberculin syringe, you can drain the entire abscess like that. So once the abscess is drained, then you go ahead and go into the stroma and gently give the intrastromal voriconazole. There you can see that hydration. It's very similar to your hydration that you see when you hydrate your side pods. Okay. So this is again one more case of intrastromal voriconazole. I'll just forward it for the sake of time. So go there. You can see that hydration throughout. So that is how you have to do it. So intrastromal voriconazole has very good results when given an appropriate time. These are one of the few cases, some few cases that we have used intrastromal voriconazole. So in cases that are not healing with this also, I think you should not lose hope. See, this is a total corneal abscess. I'm doing a freehand dissection. Nothing is left. And you can see the plaque that is there on the iris. The entire cornea has been affected. Now you gently remove the things and put in a graft. So these cases eventually would require a glaucoma drainage device, and that you can plan at a later stage. So next, in continuation to fungus, the reason I have kept Pythium is this is the most common organism that mimics fungal keratitis. So previously we were reporting it as unidentified hyaline fungus keratitis. But if you see in the recent 4-5 years, the Pythium keratitis has come out more. So how do you differentiate it from fungal keratitis? Two most important features. One is this tentacular projections that you see here, and then you have a peripheral gutter. So this tentacular projections and peripheral gutter, these are the two important things. And if you are treating a fungal ulcer and it's not healing, have a high suspicion for Pythium keratitis. So Pythium is an oomyte site, and if you see in grams, it is more like a ribbon. There are no hyphae or branches. Okay. And juice pores can be seen on blood cultures. So Pythium management, topical linezolid 1 hourly, antifungals like itraconazole, voriconazole also can be tried. Topical azithromycin, oral azithromycin is also there. But be very, very aggressive in treating these cases because it's a very invasive disease. There was also a reported case of death from Sankarnatrala, if I'm not wrong, because of Pythium keratitis. And but we still need more data to have a standard protocols in managing this dreaded infection. Next, coming to bacterial keratitis, gram positive is what we see commonly, and they're also relatively easier to manage because they're usually well defined and superficial. Whereas gram negative pseudomonas is what we should be worried about. This is what we commonly see in contact lens wearers. And here the inflammatory component is sometimes equal or more than the infective component, leading to rapid deterioration. Even sometimes in hours, it deteriorates very badly. So these are how gram-positive pairs look like. Then usually it's Streptococcus, gram-positive bacteria. It's usually atypical Mycobacteria. GNB is Pseudomonas. GPC in groups is Staph aureus. So gram negative is usually difficult to identify because it gets lost in the background. Gram positive, usually you pick up well in a microscope. So for a beginner, I think gram negative bacteria would be difficult to pick up. So bacterial management for gram positive, we usually give moxifloxacin or gatifloxacin. And along with that, we also reconstitute cefazolin and oral antibiotics similar to fungus where you have deeper infections or limbal involvement. And for nighttime, we give a ointment cover. Gram negative, I think fortified Genta and Tobra have a role to play. And this may be controversial, but I use steroids in cases of Pseudomonas where it is confirmed on thing. I usually start it after 12 hours. And once you start steroids in these cases, I think the melting is not as much as you compare when you give only antibiotics. And these cases do well And even in SCUT study, if you see, there is a particular subset of Pseudomonas that is very aggressive. In those cases, if you are able to add steroids in an early phase, then there is a 2.5 line improvement in those cases. But this should be done by a corneal surgeon and not by a regular practicing ophthalmologist. Next, you have atypical microbacteria. This is an emerging infection. Usually, you see this in post-LASIK cases or immunocompromised patient. It's a diagnostic and therapeutic challenge. The classical appearance is a cracked windshield appearance. It mimics both fungal and viral keratitis. So why atypical microbacteria is difficult to pick up? Because of its negative staining. If you see here, this white filamentous things you see here is the atypical mycobacteria. So this atypical mycobacteria, you cannot identify. That is the reason you tend to miss it out. Okay. So that is the reason you need some special stains to get it out. So atypical microbacteria treatment, amikacin, you start off with 2%. If they are not responding, then you go for 4%. Then you can add gatifloxin higher strength or moxifloxacin, erythromycin 500 mg, and that is how you can do it. At least you see for 1 month with medical therapy, and if it doesn't heal in cases of post-LASIK, you go for LASIK flak amputation and then for a therapeutic graft. Next, I would like to discuss about acanthamoeba keratitis. This you have this typical ring infiltrate, this perineuritis and intense pain, corneal melting on chronic cases also you can see. Acanthamoeba, the KOH mount, you can see this beautiful double wall cysts here. And again, in confocal microscopy, has a specific role in acanthamoeba where you're not able to pick it up in microbiology. The treatment again here is PHMB and chlorhexidine. These should be diluted to 0.2% eye drops and should be used hourly. Pain management, regular painkillers will not be there. You can either give amitriptyline or gabapentin in these cases. 2 weeks of antimicrobials. Steroids in acanthamoeba, you can start only once you see vascularization or there is any melting associated scleritis, lid edema, and the symptoms are more. In these cases, I think you should give the disease at least 2 months time with medical therapy because it's a slowly responding disease. And some people have tried DAL, but we prefer to do a TPK. Because of the chronicity of the disease, you'll have a lot of surface toxicity in these cases because of the drugs we have been using for a long time. Next, nocardia. This is a typical wreath-shaped pattern, and most commonly in our practice, we see in tunnel infiltrates that can lead to even endophthalmitis. So this is how it will look like in a thing, and this is the tunnel infiltrate. So nocardia, if you see, these are filamentous bacteria. You should not confuse them with your fungal filaments. Fungal filaments are broader. They have septae and hyphaeation. These are just filamentous, more slender and dot-like filaments. So nocardia treatment again is amikacin 2% you start off, then go to 4%, add a 4th generation fluoroquinolone. Systemic amikacin can be given, and you can also try sulfametazole with trimethoprim oral medications. So microsporidial, I think already she has covered very well, so I'll skip this slide, but just I wanted to show the importance of manual debridement. So no treatment at all, just moist cotton tip. You knock off all this things, and this is how it will look immediately after you knock it off. And microsporidial, yeah. So the take-home message is microbial keratitis, if you properly try to identify, 60% can be diagnosed by medical clinical examination. My message to general ophthalmologists is try empirical therapy only for 5 days to 1 week. If it doesn't respond, please refer to a corneal surgeon who can do a microbiological evaluation. If then, especially if the ulcer is central, if it is more than 2 mm, if the patient is child or if a patient is one-eyed, don't hesitate in referring the patient earlier. Proper dosing is very important. So the most important thing is every 1 hour dose during waking hours is important. And we make sure that the first drop falls in the clinic itself. Because once you know the diagnosis, there is no fun in asking the patient to starting the treatment once he goes home. So what we do is once the patient buys the medicine, we explain everything and we try to put the first drop in the clinic itself so that the treatment will start off there. So give the maximum medical therapy for 2 to 3 weeks. If it doesn't respond, go in for an early surgical intervention, which will have a better outcome rather than a late surgical intervention. And I would request all the ophthalmologists who see a lot of ulcers to invest in a good clinical microscope that will create more confidence in treating these conditions. Thank you for your time and attention.
So thank you, Madhu. I think that was very comprehensively covered the entire microbial keratitis. Very difficult to do for each of these keratitis. I think Dr. Prashant Bhavankule has to leave, so I will request him, Shikha, if you don't mind, to give his talk first. Thank you so much. And he's going to be talking to us about endophthalmitis.
Okay. Thank you, ma'am. 1 minute. So friends, thank you, Dr. Namrata Sharma and team Scientific Committee AIOSSC for this one opportunity to us. Well, friends, I would not be speaking only on endophthalmitis. I would be speaking more on a clinical condition where we have a inflammation on the very first day after doing a cataract surgery. So the biggest question comes: is it a sterile inflammation or is it an infection? So let's see through this presentation how clinically we can differentiate the differences between the two, and how should we be approaching a case which is presumed infective. So there are technically 4 scenarios when you have more than expected inflammation on a day 1. It can be because the surgery was quite traumatic. Second, there are certain group of eyes which are predisposed, which tend to have more inflammation. Third is a scenario when there was a very precise surgery which went on fine, that is an traumatic surgery, but still you have an inflammation. And the fourth situation, clinical scenario, would be you have more than one case which is involved. So let's move one by one. Now, if there is a surgical trauma, that is, you need surgical time is more than anticipated, prolonged phaco time, or you see when you are reviewing the patient for an inflammation, you see the signs of iris chafing, iridodialysis, you have a posterior capsular tear, a big pupil, all this speaks about a traumatic surgery. And in such cases, we should anticipate more inflammation than expected. And if you have an inflamed eye on day 1, you can better expect it to be a sterile inflammation, and initially at least treat it as a sterile inflammation with simple topical steroids and mydriatic. Then there are certain group of eyes which are more predisposed to inflammation. For example, you do a congenital cataract, similarly a traumatic cataract, or a cataract in a diabetic eye. In such cases, naturally the eye is going to be more inflamed in spite of an uneventful surgery compared to the other eyes. An eye which had more inflammation, like for example, a patient has a healed uveitis or a fuchs iridocyclitis, or a patient with a history of arthritis. Again, these are the subset of patients where you might anticipate, and rather you should be mentally ready for having more inflamed eye on day 1. Specifically, this is important cataract in a diabetic patient. We need to understand why it is important, because 20% of the cataract procedures which are happening today are happening in diabetic patients. And in such patients, more than 10% have a severe fibrinous reaction. But the challenge here is that diabetic patients are also prone for infection. Almost 21% of the cases of endophthalmitis happen in a diabetic eye. And there comes the importance of differentiating a sterile versus an infective. And in such cases, in a diabetic eye, if you have a more than anticipated inflammation, you have to be on a very close vigil. You can initially treat it with a simple steroid, topical steroids, but any deterioration, you should treat it like a case of an infective endophthalmitis. The other case is a subset, what we call a trauma, a patient who has received a trauma. And in such cases, the process is called ACADS, that is antechamber associated immune deviation. So when there is a trauma, a self-sealed capsular perforation, and there is a release of some amount of lens material where the immune system is mediated. So when you do a cataract surgery following few years down the line, suddenly there is a more than inflammation because the autoimmune system recognizes that lens protein as a foreign protein, and then because it is sensitized, and that is called ACADS. Now, the fourth situation and the more worrisome situation is when you have more than one eye having an inflammation more than anticipated. So if that happens, then is a totally different ball game. Here, most important thing is to get cool, recall all the patients which are operated on the same day. You have to discuss the details of every case, go back to the case sheet, see what was the reason. You have to go back to the surveillance report of OR, see if there is any breach in the protocol, and also do not hesitate at this point of time to take advice or a second opinion from one of your colleagues, and do involve the government official if possible. Well, coming to finally a case where you have an traumatic surgery in a single eye which has operated. Now the question comes, is it a sterile one? And this is the most wishful thinking most of us do. Why does a TAS or a sterile inflammation happen? Because of the influx of exogenous toxins or chemicals or some proteins which are liberated, which have been deposited inside the eye, leading to more inflammation. How do we differentiate? Remember, here the clinical signs are more important. You have an inflammation which starts as early as 12 to 24 hours. There is a limbal to limbal corneal edema, as you can see in the picture over here. The pressures might be high. Iris tissue might be not visible. But most importantly, if you do a retro illumination, you can still get a good glow. But if the exudative membrane is quite thick, you do a B scan on a high gain, vitreous is devoid of any opacities, then you are sure it's a sterile inflammation, and you can treat it as simple as a sterile inflammation. Why is it important to differentiate a TAS from an infective? Because even a TAS, though sterile, can lead to a permanent corneal decompensation, sometimes an intractable glaucoma and cystoid macular edema. And here the line of management is basically steroids and cycloplegic and IOP lowering measures, versus endophthalmitis, where steroids is almost contraindicated or it becomes complementary. The primary line of treatment is steroid intravitreal injections, antibiotic injections. So let us understand, if you have a case which is more than inflamed, how do we begin inflammation? And you have to go back to the history. A patient who is a named case of arthritis, or a patient who was on a miotics or prostaglandin analogs, in such cases, it is more likely you have an inflammation which is secondary to inflammation and not infection. But a patient with dermatitis, a patient diabetic, or a patient on a CKD patient on a dialysis, or a patient who is on an immunosuppressives, if you have an inflammation more than expected, it is more likely to, the diagnosis is more likely to tilt in the favor of infective. Important is, you need to remember the commonest excuse which we get when a patient is referred to us, that the patient did not have pain, hypopyon, and a red eye, and so it was not endophthalmitis, and so the anti-segment surgeon treats this patient as a sterile with a steroids. Now look at this EVA study as well as ESR studies. Almost 24% to 30% of the patient never had pain. Hypopyon was not seen in 25% of the patient. The importance in this, why it has been highlighted with color, is that pain, hypopyon, redness, though a cardinal symptom or a sign of infection, might be absent in 20 to 25%, and so should not be used as to discard or discriminate between an inflammation and the infection. You can still have an infection in the absence of these symptoms. After having a thorough history, you have to begin your clinical examination right from visual acuity. Recording a visual acuity is not only important for medical legal point of view, but also for a vitreoretinal surgeon. It is important because it differentiates, or it helps him in deciding which management it is to do. He has to opt for. Any inflammation which is more than anticipated, according to EVA study, if the vision is more than hand movements, more than hand movements, you can do simple aqueous tap with an intravitreal antibiotic. But in today's context, any vision less than counting finger, we prefer to do a vitreous tap, send it for culture sensitivity, and treat it with intravitreal antibiotics. Slit lamp examination, even a detailed adnexal evaluation, for example, a swollen lead like this, and a Roplas positive, Tear means dry eye. In such cases, the eye is likely to be it is more likely to be infective in nature, and your diagnosis should tilt more in favor of infection. A thorough slit lamp examination can also give you, for example, if there is a wound leak or there is a suture abscess, suture infiltration. In such cases, remember, it is more likely to be infective in nature. And once you look at the cornea, you can very well make out such a ring infiltrate, usually points a finger towards the infective reason. Antechamber, flare and cells should be graded and documented because these are very important medico-legally. If this patient lines up in sues you, you should be aware. And so documentation is absolutely important, noting down the cells and flare as well as the height of the hypopyon, how many millimeter it is. Many a times because of the inflammation, the iris and the color pattern of the iris is masked, and therefore you would not be able to comment. But indirect signs like having a big pupil, sometimes an iris capture can give you a clue towards sterile variant of it. Similarly, IOL position also can tell you about the trauma during the surgery. Now, regarding recording the intraocular, you have to do applanation tonometry with a sterile technique. Usually, if it is infective in nature, pressures are usually low. But raised intraocular pressure can happen in TARS and viral iridocyclitis, and that should be your differential diagnosis in such cases. Posterior segment has to be evaluated with slit lamp biomicroscopy as well as indirect ophthalmoscopy. And the grading at the amount of the fundus which is seen, whether the disc is seen, the first order, subfinal order, blood vessels are seen or not, has to be mentioned because that gives you you can grade the media haze based on that. Wherever you cannot evaluate the fundus, B-scan is mandatory because it not only helps you in understanding how much is the vitreous opacities, how dense is the vitreous opacities, that will give you the intensity of inflammation, but presence of sometimes membranes can give you the nature of the infection, how severe is the infection. For example, in this particular case, this was a patient done by our postgraduate where mild opacities were noted. But look at the decibels at which it was done. It was done at a low gain. And the same patient, when it was repeated at a high gain, you could see such a vitreous studded with so severe an opacities. So whenever you are doing a B scan and trying to assess the involvement of the vitreous, do it on a high gain. And high gain will be able to pick up the vitreous involvement whenever in such cases. And these are the moderate and dense opacities which will help you. Now, this particular patient was being treated as a case of endophthalmitis, and simple B scan could give us the clue. Here was a biconvex type of a structure, which is nothing but a nucleus drop. The anti-segment surgeon had not shared the history. He said it was an uneventful surgery. There was an exudative plaque on the IOL surface, and so patient was initially treated as a case of endophthalmitis. And when we did a B scan, when the patient was referred to us, we could see such a nucleus over there. And so it did not need any further intravitreal injection. We just had to do vitrectomy with nucleus removal, and with steroids, the patient came up. Similarly, this is another case of an IOL drop where a patient was being treated as a case of an endophthalmitis. And while in this case, you can see a nucleus as well as an IOL drop. So as an anti-segment surgeon, whenever you are referring it to a vitreoretinal surgeon, being frank and being truthful and telling them that real truth of the can prevent a lot of, can help us in deciding a proper management for this. Now, B-scan also helps you in picking up the involvement of the ocular codes. Involvement of ocular codes speaks about early panophthalmitis and the line of action management totally different changes as well as the prognosis changes. So after having done a complete inflammation, but you're not sure that, I still feel it is infective, it's a plus minus time. So whenever you're not sure, the best thing you can do when you're thinking more in favor of a sterile inflammation is just increase the frequency of topical steroids as well as topical antibiotics. Put the patient on some cycloplegic, but do repeat an evaluation 4 to 6 hours later. Remember, whenever in doubt, never use any oral steroids, never do AC wash for removing the thing, because remember, anti-chamber wash to remove membranes is you are going to induce more trauma and more inflammation. So never do an anti-chamber wash or never use oral steroids whenever you are in doubt. Simply increase the frequency of topical steroids and cycloplegic. Repeat a slit lamp examination as well as indirect ophthalmoscopy after 4 to 6 hours. And if still in doubt or if there is any worsening at that point of time, it is prudent to treat this patient as an infective case. So how do you treat whenever you are doubt that you are thinking it as an infective case? You need to treat it with intravitreal antibiotic, as well as at the same time you need to collect some sample from the eye, either from aqueous or vitreous, to send it for culture to establish the microbiological diagnosis. For an anti-segment surgeon, aqueous tap is very easy. You are used to giving intracameral antibiotics. Similarly, with a 26 gauge needle mounted on a 1 ml syringe, just under topical anesthesia, you have to withdraw some amount and you have to cap the needle, remove the extra air bubble in it, and immediately send it for gram culture and PCR, whatever the facilities are available. So this is the simplest thing. Once you acquire some sample, aqueous tab, then you have to inject into the vitreous cavity intravitreal antibiotic, and intravitreal antibiotic is the mainstay of the treatment. Besides that, you need to also give systemic antibiotic as well as topical antibiotic, steroids, and complementary things. The second best, the most important best part would be to, if you need to have the real sample from the site where the inflammation is lodged, that is going to be the vitreous tab. But vitreous tab does not mean poking your needle into the vitreous cavity, because that will lead to traction. It is better to go with a vitreous cutter, and that can be left for a vitreoretinal surgeon. But as a primary anti-segment surgeon who is placed at a far distance, you can simply do an aqueous tab and just prick one intravitreal antibiotic, so that the patient gets some time, a breather time, the inflammation responds to it. And so the time which is lost between referring from an anti-segment surgeon from a peripheral area to the vitreoretinal center, the patient is already on treatment, and that is very much important in preventing at least very purulent type of infections. Remember, the aqueous tab culture rate is in the best of the lab. You can grow even in a clinically proven and endophthalmitis. The isolation rate is only 27%, while of a vitreous is almost close to 60%. So negative cultures does not mean that you do not have an infection. Remember, it is the limitation of this culturing technique that where you can isolate the organisms. The best thing whenever you have an infection as a vitreoretinal surgeon is to do a vitreous tab, which also gives you an advantage of making it as diagnostic as well as a therapeutic advantage. Diagnostic means you get a sample for culturing, and therapeutic means you are removing the vitreous best to the maximum possible extent. So you decrease the load of bacteria, toxins inside the vitreous cavity, and at the same time you inject antibiotic, and thereby helping in resolution of the disease per se. And this is the microbiological study which you should order for whenever you acquire a sample either from aqueous or thing. Now, regarding PCR, most of the people who are situated in periphery do not have an access to PCR. But remember, the advantage is that even the smallest sample size you can help it in identifying the organism. But remember, antibiotic sensitivity is not possible. PCR is limited to higher centers, and though it has an increased isolation rate, but remember, many a times some of the dead filaments or a passive contaminant can also give you a false positive PCR. Once again, let me highlight, many a times patient anti-segment surgeons say you did an aqueous tab, you did a vitreous tab, it was negative. I was saying that it was a sterile inflammation. No. Aqueous, again, let me remind you, the isolation rate from an aqueous is only less than 30%, while from a vitreous is 60%. Negative cultures does not mean that it was not an endophthalmitis. It can be because of fastidious organism, insufficient sampling, or very rarely sterile endophthalmitis. Now, once you inject, you see the patient 24 to 48 hours, 24 hours later. And if you are still not getting the clinical response which is adequate enough, and you do not have an access to a vitreoretinal surgeon, you should definitely repeat a culture along with repeat intravitreal antibiotics, because sometimes you might be treating with an antibiotic which is more of a broad spectrum rather than the specific. And today there are many organisms which are become resistant to our routine antibiotics, which we use as a broad spectrum antibiotic. So I think I will just run through one or two cases, because it's a series of almost 10 cases, but for want of time we have already overshot. This is case one. This is few cases. Yes. Patient who underwent cataract surgery or heart. Okay. So this is a pre-recorded one, so I will just skip over here. So friends, whenever in doubt, remember it is prudent to treat a case of an inflammation as an infective case rather than a sterile case. If you want to be definitely want to try it, do give a trial of topical steroid, never an oral steroids, never AC wash, and if it is still deteriorating, it is prudent to do inject one intravitreal antibiotic, which will save a lot for the patient. Thank you.
Thank you so much, Prashant. I think that was a much needed talk on how to distinguish infection with inflammation, and relevant to all the general ophthalmologists, because the first thing that comes to mind is inflammation. We don't want to believe it's infection, although you said otherwise, always treat like infection. So thank you so much for that. Anybody would want to ask anything? Piyush is not here. I think he's left. Yes, Ellen, before we move to the next talk.
Sir, what is your preference of intravitreal antibiotic, if at all, if it has to be given?
Yeah, for me, I am still using vancomycin with ceftazidime as a first line of treatment. Okay. And if it is a late presentation, I am having some doubt of fungal, I am looking at a chronic picture, I might add an amphotericin to it.
So
And,
just a quick question. So one quick question. If you are suspecting a gram-negative organism or a Pseudomonas end-off, in such situation, do you change the antibiotic or you still go with the same?
Yeah, if it is a very purulent one where we are seeing cornea infiltration very rapidly progressive, today now colistin is my first line of treatment in such cases.
So you go for colistin or a piperacillin tazobactam combination?
That
Either.
also we cover up with means that's what the clinical picture definitely helps us in deciding. I told about the in an inflamed eye on a very first day, not a very badly like very total cornea which has become infiltrated within first 24 hours, then the line totally differs.
Yeah, I think we can move to the next talk. Pranita, will you please
Thank you, ma'am.
introduce? Thank you, Prashant.
Yeah.
Dr. Shikha.
So our next talk is going. Our next talk is going to be by Dr. Shikha Gupta, ma'am. She's going to talk about blebitis. She is an additional professor currently working at Dr. Rajendra Prasad Center for Ophthalmic Sciences, AIIMS, New Delhi. She's done her MBBS, MD, and senior residency from AIIMS and has co-authored over 200 papers. Has an H-index of 32. She's a recipient of multiple international and national awards awarded by ARVO, the ASGLN Crandall Humanitarian Award, the DB Chandra Disha Award by AIOSSC. And she is spearheading the glaucoma research by guiding over 20 thesis candidates and PhD students as well under her mentorship. Ma'am, we welcome you for your talk on blebitis and Bleb-related infections.
The kind introduction, and thank you, Dr. Namita Sharma ma'am, for having me here and giving me this opportunity. So I'll be talking about Bleb-related infections. It is very, very important topic because sometimes we overlook the Bleb infections. Sometimes the patients present to us with conjunctivitis and they've already had some filtering surgery in the past. And these people, if they are not taken care of at the right time, they may progress to Bleb-related infections and may lead to, in fact, endophthalmitis, which may become non-salvageable, especially children who have been operated. So we need to discuss how we can differentiate between conjunctivitis or blebitis and Bleb-related endophthalmitis. So usually they present to us late, that is 1 month after undergoing filtering surgery. They're called early onset BRI when the infection presents within 1 month after glaucoma filtering surgery. In these cases, the cause is usually local. Sometimes there's, sutures they give away and there's a leak, frank leak. Sometimes there may be dehiscence. Sometimes there may be, micro leaks, which the surgeon may not know. And as a result of which the infection develops, but this is not so common. Late onset BRI is usually more common, which which presents after 1 month of surgery. The reasons being, of course, related to the bleb, which are dysesthetic because of the use of the mitomycin C. So we'll be coming to this point. Bleb-related infection can be categorized in 3 stages. Stage 1 is when the inflammation is localized to the bleb. And so it is a white on red appearance, which we'll be seeing in the future slides. In stage 2, there is accompanying anterior chamber inflammation, which is seen by the presence of cells, flare, or even a frank hypopyon. And in stage 3, it progresses to bleb-related endophthalmitis, where there is vitreous involvement. So according to different studies and the style of surgery, whether it is fornix-based or limbal-based, the concentration of the antimetabolites that may be used, the 5-year risk of blebitis and bleb-associated endophthalmitis can range from 1 to 7% at 5 years. The collaborative initial glaucoma treatment study, it showed that the risk could be 1.5%. And another study done in Japan, it showed the risk to be around 2.2% at the 5-year follow-up. But the risk again can vary. It can be more, especially in children, and especially if the mitomycin C used at the outset is greater in concentration. So the blebitis, it looks like a localized redness. Discharges there. They could be, so this is a typical white on red appearance. The bleb is totally avascular. If we do a Seedles testing in this case, it will turn out to be positive. We can see that the superficial conjunctiva is actually diseased. It is pathogenic. And even if we treat this infection, this has a chance of recurrent infection. So conjunctivitis doesn't have any involvement of the bleb per se. It is a diffuse conjunctivitis. And it is usually treated by antibiotics and doesn't need to be monitored so frequently. But if it occurs in a patient who has undergone a filtering surgery in the past, of course, that patient needs to be monitored more aggressively than a routine patient. When we come to blebitis, this white on red appearance, basically now the conjunctival infection has gone through the bleb and there is accompanied anterior chamber reaction. So it is imperative that any patients with conjunctivitis who has had a filtering surgery in the past is looked for properly in the anterior chamber for any reaction. It can be 1+ reaction in the beginning, which is easy to control. But a frank hypopyon may also be seen, and it has been seen that these infections are overlooked sometimes, even in the emergency. So these patients need to be aggressively treated with both fortified topical antibiotics, and sometimes if they're not responding so well, we may also give subconjunctival vancomycin infections. And of course, when it progresses to bleb-related endophthalmitis, we see a vitreal infection or inflammation. If the media is hazy, we can see that on the ultrasound. And as Sir has discussed thoroughly the management of endophthalmitis, they may require intravitreal antibiotics as well as PPV in near future. So if there is a frank bleb leak at the outset, it increases the risk of bleb infection by 26 times. So whenever a patient of trabeculectomy comes to you for follow-up and his pressure is good or even the normal low range, it is important that we check for the bleb, we check for the Seedles test, we check for the overlying conjunctiva. Initially, these blebs may do fine, but eventually over time, as the MMC is a modulator drug, it keeps on modulating the superficial conjunctiva, and the Seedles positivity may appear later down in the course. So it is imperative that we look at the bleb area every time. If it is Seedles positive, we have to treat that patient, do a conjunctival advancement or replace it with healthy conjunctiva before any such thing happens. So it becomes a vicious circle. Suppose there is the conjunctiva is healthy and the patient develops blebitis, but it can lead to the superficial conjunctiva getting necrosed and debrided, and eventually this may lead to a bleb breakdown. So when there is a blebitis, whether it was started because of a poor conjunctival surface or it led to poor conjunctival surface, these blebs need to be treated in the long run once the acute infection heals. So other than that, there could be thin avascular blebs. Sometimes a nasal or an inferior bleb, which is in the exposed area, may lead to higher chances of infection. The use of intraoperative mitomycin C, if we are using a higher concentration for a longer duration, it may lead to early development of this kind of appearance. So limbus-based blebs, which are, we generally do that kind of surgery in children where we cut the conjunctiva here, and it can lead to a ring of steel formation and use more often localized blebs, which can more often lead to infection compared to a fornix-based blebs. It is said that hypotony leads to bleb-related infections more often. And of course, chronic antibiotic use may lead to these kind of infections. Other than that, some patient-related factors, like it's said that black race, patients with diabetes or who are immunocompromised, who are chronic contact lens users, or they have concurrent infections like nasolacrimal duct obstruction, they may proceed to Bleb-related infections more often. Other than the Bleb, we also have infections which are seen in GDDs. And if not recognized in time, these patients may also present to you on a routine follow-up. And you have to check the area of the tubes. In this case, that was not patch grafted well. And you can see that conjunctival erosion has started taking place over the tube. And this will eventually lead to pictures like this, where the patient will come to you with endophthalmitis. This was a patient who was operated outside, and we can see that the whole tube was lying over the top of the cornea. So these cases have to be really evaluated well before they go into any infection for their conjunctiva, overlying conjunctiva. So when the patient presents to you with infection, and it's important that we do serious testing after we heal the initial part of the infection, and look for any inciting factors why this patient developed this, because these patients have a chance to go into recurrent infections and eventually lose vision if we do not treat them well. And rule out any posterior segment evaluation, collect our samples from whatever source we have. If it's only conjunctivitis or blebitis, we can collect it from under the area of the bleb also. And sometimes when there is frank hypopyon, we can go for aqueous or vitreous trap in case of vitritis. And even before microbiological confirmation is there, we need to start the patient on empirical antibiotics. So Staphylococcus is most often the inciting organism, especially in early cases, and Streptococcus causes this kind of infection in late cases. We also see, gram-negative infections and blebitis, which are much more common than routine conjunctivitis, and the risk factors are poor immune status of the patient. So for the blebitis, we don't wait for any result of the microbiological sampling, but we start with fortified antibiotics, just like for a corneal ulcer. We can give empirical vancomycin or piperacillin for gram-positive organisms and tobramycin to cover for gram-negative organisms. And after 48 hours of the patient is responding to these medications, we can switch them to less frequent dosing. We can also use fourth generation fluoroquinolones, which are supposed to be broad spectrum antibiotics. And if the patient responds and we see that the infection is healing and it's more of inflammation, we can add topical, milder version of topical steroids. However, if it is blebitis, these patients are very difficult to heal sometimes because the conjunctiva is poor and the infection remains localized under the bleb. In that case, perilesional subconjunctival vancomycin is often injected in a dose of 1 mg per 0.1 ml. And if endophthalmitis, it is important that we give intravitreal antibiotics on the first go whenever the patient presents to us. Rule out vitritis. If it is there, we need to give intravitreal antibiotics immediately and then refer to the retinal surgeon for a possible vitrectomy, because these patients are difficult to heal with only antibiotics because of the poor bleb, which is a continuous source of infection. So after we heal the acute infection stage, it is important to repair the leaking bleb. This is one of the most important difference, that a surgery is imperative in these patients after it heals. And we have different options, like conjunctival advancement can be done. The area of the dysesthetic bleb can be removed and it can be overridden with the normal conjunctiva from the healthy tissue above the area of the bleb, or even a graft can be taken from the fellow eye or from the nasal or the inferior conjunctiva. We can also go for intra-bleb AMG, where this we can see after 3 months, we had put an AMG inside this bleb and it is healed so well. And the side effects of the conjunctival advancement, like ptosis, are done away with in these cases, and they really heal well. If the sclera is missed, on AIOSSC you see that the sclera is also showing dehiscence. We need to patch it up with a patch graft of a sclera or a cornea. And we can also do compression sutures just to reduce the area or the surface of the bleb. And sometimes it also helps in covering up small areas of microleaks if they are localized. So we often do compression sutures surgery in areas with very minimal leakage, long-term also. So if we have a tube exposure, we need to urgently patch it up with the graft, and sometimes tube explantation is also required, because these continuously act as a nidus of infection, and even after everything we have given, we have to actually remove the tubes to heal the patient with this infection, and they are very difficult to treat. So usually only blebitis, if the infection is localized only to the bleb area, the prognosis is good and they retain good vision, more than 6/12 in most cases. However, if they proceed towards bleb-related endophthalmitis, the visual outcomes are typically poor. And similarly for tube-related infections, they are difficult to manage, and most often tube explant is required. And sometimes the cases otherwise may go on to panophthalmitis scenarios. So it's very important that whenever we are doing a trabeculectomy surgery, that we prevent any such infections in future. And there are various robust steps that we should be taking, such as we should be doing a diffuse dissection. We should be doing phonics-based trabs where we have more diffuse dissection and the fluid can accommodate throughout the superior phonix rather than to a smaller area. The dose of MMC should be very less. We typically use 1 minute 0.1% of MMC in primary cases. And they should be washed away very carefully, and we should avoid any inferior bleb placement. So to conclude, vigilant post-operative monitoring is the key to early detection, and prompt diagnosis and aggressive treatment can help salvage our patient's vision in most cases. Thank you very much.
Thank you, Shikha. I think I learned the most from your talk because of so many things that we as corneal surgeons don't know, and so many things are important.
Same goes for me, ma'am. I learned so much today from everybody's talks.
Still, it was really, and it's a topic which is less talked about. We don't talk about it much. Maybe the glaucoma specialists do talk about it, but something that we don't talk about. And we've seen cases like the way, you showed that phlebitis is there and then you don't know what to do. Very interesting is the fact that you can give even subconjunctival vancomycin.
Yes,
So
ma'am. We
that was
usually avoid it. I didn't mention it. We usually avoid it directly under the bleb because it can lead to leakage. So we give away from the area of the bleb, or even if we can give to the inferior conjunctiva, the superior conjunctiva is all friable, then also it is, we often do that too.
Okay. And any other antibiotic like the imipenem or the meropenem you've
It
tried?
depends on the antibiotic susceptibility which comes on later on. Yes, ma'am. So depending on the results, we can do that.
Any question, Ellen, Pranita, Praful, Madhu? Anaga is also here. I
That's
see.
the advantage of being a glaucoma person. Nobody has a question.
Ma'am has already covered the entire topic so really well.
Yeah, covered it so
This
well.
whole session has been really on an ocular infection. We have learned so much, and almost everything has been covered so nicely now.
So thank you so much, and I would like to thank each one of you because it was at such a short notice, and everybody agreed to pitch in. Thank you, Shikha. I know I told you just day before yesterday. Thank you so much, and we would like to thank the entire audiovisual team who's at the back, who's helping with this, particularly Mr. Sunil, Mr. Bhupender from the AIOSSC Scientific Committee office, and all the speakers, all the panelists, all the people who watched it, and of course our sponsors, Lupin Blue Eyes, who have supported this webinar. Thank you so much, and hope to meet you on another platform again with another interesting topic. So Praful, thank you.
Thank you so much, ma'am.
Thank you.